Welcome back to our 15-part masterclass series. Today, we're diving into part 13, and we are tackling the high-stakes world of sepsis sequencing. Look, if you work in inpatient coding, CDI, or revenue cycle management, you already know sepsis is a massive target for payer scrutiny. It's like a bullseye on your charts. So today, we're going to bulletproof your documentation by mastering the fundamental rules and, more importantly, the tricky exceptions.
So you might be wondering, why does sequencing matter so much? Well, misidentifying the principal diagnosis isn't just some innocent typo. It leads directly to improper DRG assignment, brutal audit clawbacks, and just massive compliance red flags. Payers aren't just looking at your codes, they're reading the story those codes tell. If the sequence is wrong, your revenue literally walks right out the door.
Here is our roadmap for today's explainer. We'll cover the core sepsis sequencing rules, dive into present-on-admission nuances, look at non-infectious triggers, break down the 5 crucial non-PDX exceptions, and finally, tie it all together with CDI and revenue integrity.
Let's jump right in with Section 1, Sepsis Core Sequencing Rules.
Okay, let's anchor ourselves in the absolute baseline rule found in ICD-10 CM Guideline IC1.D.4. This is the classic systemic versus localized scenario. Imagine a patient is admitted for both sepsis, which is a systemic infection, and an acute localized infection, like, say, severe aspiration pneumonia. The guideline here is absolute. You must sequence the underlying systemic infection code first as your principal diagnosis, or PDX. The pneumonia, that gets assigned as a secondary diagnosis. Basically, systemic always trumps localized when both are driving the admission.
Building on that baseline, what if your patient has severe sepsis? Well, our core rule holds steady. The systemic infection is still the principal diagnosis. But now you've got to add a code from subcategory R65.2 as a secondary diagnosis to accurately capture that severity. But, and this is a massive CDI catch, you cannot just guess it's severe. Severe sepsis requires explicit provider documentation. The chart has to clearly, unmistakably link the organ dysfunction directly to the sepsis.
Moving on to Section 2, Present on Admission Nuances.
Now we're introducing our first major compounding variable, and that is timing. In inpatient coding, timing literally changes everything. A condition is present on admission, or POA, if it exists at the exact time the order for inpatient admission occurs. Very straightforward, right? But this begs a really big question.
What happens if the patient is brought in for a localized infection, but the sepsis itself doesn't actually develop until after they hit the floor? If the sepsis was not present on admission, our baseline rule completely flips. The localized infection, the whole reason they were brought into the hospital in the first place, remains the principal diagnosis. The sepsis, because it developed post-admission, gets bumped down to a secondary diagnosis. As an auditor, I really can't stress this enough. Always trace the timeline of the clinical documentation.
All right, let's look at Section 3, Non-Infectious Sepsis Triggers.
Our second major variable is severe non-infectious insults. Sepsis doesn't always start with a simple localized infection, you know? Sometimes it's triggered by catastrophic trauma, like extensive burns. When these collide, which code gets the top slot? Well, it all boils down to the primary focus of care. If treating the trauma was the primary focus, you sequence the non-infectious condition first. If treating the systemic infection became the main focus, then you sequence the infection first. And if they equally meet the definition for PDX, the guidelines actually state either may be assigned.
That brings us to Section 4, the 5 non-PDX exceptions.
We've established the baselines, so now for the climax of this explainer. The 5 crucial scenarios where standard rules are just thrown right out the window, and sepsis is deliberately not the principal diagnosis. Think of this as your ultimate audit defense cheat sheet. We actually already covered Scenario 1, sepsis not present on admission. Scenario 4 is also pretty straightforward. If sepsis isn't the primary focus of care, it can't be the PDX. But Scenarios 2, 3, and 5, those are highly specific clinical situations that frequently trip up even the most experienced coding teams. Let's look closer.
Pay special attention to these 3. First up, Exception 2. If your patient has post-procedural sepsis or an infection due to an implant, the complication code, like T81.44XA, must be sequenced first. The whole systemic first rule, completely overridden. Next, Exception 3. If the admission is for hemolytic uremic syndrome associated with sepsis, code D59.31 is your principal diagnosis. No debate. Finally,
Exception 5 are modern reality, COVID-19 and sepsis. When a patient presents with both, sequencing ignores the standard localized rules entirely and depends solely on the primary focus of the admission.
Finally, Section 5, CDI and revenue integrity.
So knowing all these complex sequencing rules is great, but it's really only half the battle. Defending them against payer auditors? That requires bulletproof clinical documentation improvement. CMS is very, very clear. Clinical evidence must be present in the medical record to support your code assignment. Say you've got a patient with pre-existing chronic kidney disease who has a baseline creatinine of 1.5. They should only trigger a renal dysfunction point for severe sepsis if their creatinine spikes to 2.0 or higher. If those clinical indicators don't match the diagnosis, or if the source of infection is just missing, you absolutely must query the provider. Because let me tell you, an unsupported principal diagnosis is an instant clawback.
And that wraps up our deep dive into sepsis sequencing rules and exceptions. We've covered the core rules, those tricky POA nuances, non-infectious triggers, and the 5 critical non-PDX exceptions. But I want to leave you with a quick thought. If a payer audited your facility's last 10 severe sepsis claims today, would your documentation hold up, or would you be handing back revenue? Stay tuned for Part 14, where we break down official AHA coding clinic rulings, tackling postpartum sepsis, transplanted kidney pyelonephritis, aspiration pneumonia, and toxic shock syndrome. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.